When the patient arrived, I went to assess him, and I noticed that he was very hot to touch and not sweating at all. We got a rectal temp, which he was not fond of, and it read 107.9, which is about 42 degrees Celsius. To this date, that's the highest temperature that I've ever seen in a patient. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today we're talking about heat stroke. As I sit in my air-conditioned podcast studio, or as my kids call it, the podcast closet, because it's literally a closet that we turned into a recording studio. Anyways, outside it is 95 degrees with 80% humidity, making it feel closer to 100 degrees out there. I live in Florida, and it's like this from the end of April through September, about half the year. So I thought it'd be a good time to talk about heat stroke. So as a rapid response nurse, I don't respond to many heat stroke cases anymore, as those are usually stabilized rather quickly in the ER. So let me take you back about 15 years to my days as an ER nurse to tell you about a patient who came in with all of the classic heat stroke symptoms. So we'll talk later about heat exposure illness classifications, from minor heat-related illnesses like heat cramps to heat exhaustion and the most severe heat stroke. We often think about heat stroke as an illness for people who have trouble regulating their temperature, like little children or the elderly, but this guy was in his 20s. So we get notification from EMS that they're bringing in a 20-ish-year-old male who is found acting strangely at an outdoor music festival. Their report sounded something like this.
We're inbound your facility with a 20-year-old male, chief complaint, altered mental status. We were dispatched to him via law enforcement's request. He was found agitated and aggressive, wandering around talking to himself at the music festival. We established an IV, started a liter of saline, and then the patient began having tonic-clonic seizure-like activity. We gave 5 milligrams of diazepam. That appears to have resolved this seizure, and now he's in a post-ictal state. Current vital signs are heart rate 132, blood pressure 90/50, respiratory rate 36, oxygen saturation 98%. We're about 5 minutes out. Any further questions or orders?
That was the report we got. We're thinking some sort of drug involvement, right? Young male, music festival, seizure. I mean, I hate to assume, but when you see enough of the same type of chief complaints with similar stories, you start to make predictions before the patient even arrives. But what kind of drug combinations could do that to a person? I mean, I don't know, but we were ready for anything. When the patient arrived, I went to assess him, and I noticed that he was very hot to touch and not sweating at all. We got a rectal temp, which he was not fond of, and it read 107.9, which is about 42 degrees Celsius. To this date, that's the highest temperature that I've ever seen in a patient. So we knew rapid cooling was the initial treatment, but we also wanted to get some diagnostics to rule out other possibilities for his altered mental status, for his hyperthermia, and for the seizure. The hospital I was working for was not a burn center, and so they didn't have access to ice baths. But we rolled the patient and placed a cooling blanket under him, stripped him down, placed cool washcloths all over him, ice packs in his neck, his pits, and his groin, and I got cold IV fluid from the pharmacy. We dropped the temperature in the room and dropped an NG tube for ice water lavage. Again, this was 15 years ago, guys. Don't come at me. I don't remember how long it took to get his temp to normothermic, but it didn't feel like that long at all, honestly. His labs came back all wonky. His electrolytes were all out of whack. His kidneys had taken a bit of a hit. He had some rhabdomyolysis going on with an elevated CK, And even though he was rapidly improving with the IV fluids and all the supportive measures, he definitely required admission to the hospital. I don't actually know how he did after my shift ended. That's one of the downsides of being an ER nurse, is not knowing the outcome of your patients. However, I imagine he did fully recover, and he was young, had no other comorbidities. He probably was discharged. Okay, but how did he develop heat stroke in the first place? Let's start by differentiating between all the spectrum of heat-related illnesses. So the term heat stroke is thrown out a lot, especially in the media, right? I have patients checking in the ER saying, I think I'm having a heat stroke. However, if the patient can form a clear thought and a sentence like that, it's probably not heat stroke. They may be having heat exhaustion symptoms, yes, but heat stroke is called heat stroke for a reason. It's associated with mental status change, seizures, even coma, which is also how some strokes present. So heat-related illness can be seen in both exertional and non-exertional type situations. Think like marathon runner or marching band practice or military boot camp versus an elderly person in their recliner without air conditioning or the resources to cool themselves. Exertion does not have to be a precursor for the heat-related illness, but it does help point us in the right direction towards a diagnosis. My mind directly goes to heat-related illness when I hear the patient was picked up from football practice more than they were found at home on their couch. So I mention this so that you can keep it on your radar, especially for the elderly. So heat can lead to volume and electrolyte depletion. This can result in muscle cramps, headache, nausea, fatigue, syncope, and generalized malaise. But no alteration in mental status, so like no confusion, disorientation, delirium, agitation, etc. And the temp, when it comes to just heat exhaustion, will be less than 41 degrees Celsius. I also want to clarify that external heat exposure that causes hyperthermia will be unaffected by any antipyretics. Fever, which is different because it's caused by the hypothalamus reacting to cytokines, and it's like internally creating this rise in body temperature. So things like acetaminophen or ibuprofen, they can lower hypothermia from fever, but they're not going to help your patient with environmentally induced hyperthermia. When environmentally induced hyperthermia reaches greater than 41 degrees Celsius or 105.8 Fahrenheit, and there's altered mental status like agitation, confusion, delirium, coma, even seizures. Okay, so now we've crossed the threshold from heat exhaustion to heat stroke. Some classic assessment findings are tachycardia, tachypnea, hypotension, hot, dry skin, often with no sweating, and then that altered mental status, which can range dramatically from like a hyperactive delirium to obtunded or coma. Some of the complications of this extreme temperature, low preload, and altered electrolyte state are acute kidney injury, both from the low volume, but also maybe a little bit of rhabdomyolysis, seizures, both from the high temperature, which upsets the neurons, the hyponatremia, and some cerebral edema, GI disturbances from low flow to the gut, coagulopathies, even like DIC, and then, of course, all of the cardiac disturbances, all of like the arrhythmias that come from electrolyte abnormalities. So those all need to be managed with supportive therapy. But the first priority, once you discover heat stroke, is rapid surface cooling of your patient. The goal is to rapidly reduce the body temperature. And you can and should do this by multiple means, not just one. The most effective is ice bath, like an ice water bath. And most burn centers have these, but not every hospital has access to one. A few years back, I heard on the Emergency Medicine Cases podcast, Dr. Swaminathan described the best idea that I wish I would have thought of. He suggested creating an ice bath with a body bag. So we all have ice, and we all have plastic body bags. So you position the body bag so that the zipper is open, like to the top, and transfer the patient into the body bag. Fill the base of the plastic body bag with ice and tap water to create like a slurry of ice water. Then zip the bag around the patient, creating a little cooling cocoon for your hyperthermic patient. Now, before you make your patient into a chili burrito, there are a few things you want to accomplish prior to zipping up the chillin' wrap. First, you need IV access so that you can administer cold IV fluids and other medications to treat the multitude of potential complications. Second, you need a way to monitor core temperature. Either rectal, bladder, or an esophageal probe should be in place. My preference for this type of situation would be a bladder probe, but do whatever your hospital has access to. And third, a way to monitor vital signs.
Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there.
So once you have those items, you have an IV, a core temperature monitor, and a way to monitor vital signs, then you're safe to zip her up and let the frosty taco work its magic. Now keep in mind that this patient may seize or need to be intubated for airway protection and or to allow the amount of sedation that's needed to keep them calmly in the ice slurry or to prevent shivering. So just be prepared for all of those things while your patient's all wrapped up in the bag. Some other ways to drop the core temperature are cold IV fluids, like I had mentioned, and other methods of surface cooling are lukewarm water spritzes or cool washcloths, ice packs in the neck, axilla, and groin, cooling blanket under but not over your patient because you don't want to prevent evaporative cooling. You can cool the patient a bit with things like ice water lavage, but that is very labor intensive, let me tell you, and it's also not near as effective as the surface cooling methods that I've already described. There's also evidence to support cooling the patient through the respiratory system. So either adjusting the temp on the ventilator or just using high flow, cool, not heated oxygen through the nares to cool the patient. But whatever methods you use, you want to watch that temperature closely. And as soon as the patient gets to about 39 degrees Celsius or 102 degrees Fahrenheit, stop the cooling measures and allow the patient to continue cooling on their own. You are no longer in the danger zone of hyperthermia, and the body can usually do the rest of the cooling on its own without your help. In fact, there's risk that our efforts can overcorrect the temperature and make the patient hypothermic, which has its own risk. So evidence shows that we should stop once the temp gets moving in the right direction. The one last question that I have not answered yet is, why did this kid develop heat stroke? Well, there are a few things that put patients more at risk of heat stroke. Age. The very young and the elderly have a harder time regulating temperature. Medications like diuretics can lead to dehydration, or beta blockers, antihistamines, antipsychotics, and some antidepressants can affect your ability to thermoregulate. Alcohol and other drugs that alter your ability to reason can cause a person to ignore the signs and symptoms of heat exhaustion and continue with strenuous activity or stay out in the heat longer or forget to stay hydrated, leading to heat stroke. And finally, there's something to heat acclimation. It takes a few weeks for us Floridians to acclimate to the heat every single year. But as the temps are on the rise in, say, April-ish, our bodies start to adjust it. But people who, say, traveled from a colder climate and are visiting a hotter climate, they have not yet climatized to the heat and the humidity, and they will therefore be more likely to develop heat stroke than someone whose body has adjusted to the hot temperature already. So, turns out this young man had been on quite an ecstasy bender and had been dancing and running around the heat and was probably not taking note of his symptoms of heat exhaustion, not drinking water, and not taking breaks from the heat, and continued to exert himself, which led to his even more altered mental state, rhabdomyolysis, and ultimately seizures. So, don't do drugs, guys. It's just not worth it. All right, let's wrap this thing up. Heat stroke is different than fever and should not be treated with antipyretics. You're wasting your time with them and possibly worsening renal or liver function. So don't bother. Next, heat stroke is much more severe than heat exhaustion. So make sure you use the correct terminology, and heat stroke should be treated quickly and aggressively with a multimodal approach to cooling. Immersive cooling is the gold standard, so an ice bath is preferred, but you can get pretty close to the effective cooling power of an ice bath with a cooling body bag burrito. If you've done this before, can you please message me? I want to know all of the tips for how to make this the most effective as possible, because I've never actually done this on a real patient being removed from the ER for all these years. All right. You can also cool the patient through ice packs in the groin and harnessing the power of evaporative cooling by spritzing or wiping your patient down with lukewarm water. You can administer cold IV fluids and even cool the patient from the inside out with ice water lavage into the gut or the bladder, or cold air through the nares or the ET tube. Remember that your patient may need IV medications for sedation, to control shivering, or to treat seizures. You may have to intubate these patients if they're obtunded or they develop status epilepticus. Even though cooling is important, airway is still the priority, and so you'll likely be treating more than just the temperature as you're getting labs back and discovering all of the complications that they have developed as a result of their hyperthermia. And finally, monitor that temp closely and cease all cooling measures once the patient's core temp gets to about 39 degrees, and allow the patient to continue their thermoregulation and prevent overcorrecting towards hypothermia. Alrighty, I put a link in the show notes for you to learn more from Dr. Swami, and as always, feel free to message me on Instagram if you have any further questions. Till next time, folks, stay cool out there and don't forget to stay hydrated.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.